Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Today, we're honored to host a distinguished guest who has made remarkable contributions to both hematology and rheumatology, Dr. Thomas Ortel. This is one of several special episodes that we have crafted for a series that we're calling ACR Convergence on Air. It's the same podcast you've come to love, but featuring guests who are presenting important work at ACR Convergence 2023. Dr. Ortel has a lecture entitled Thrombotic Microangiopathy, Challenging Cases and Treatments during Saturday's review course, and we thought it would be very useful to sit and chat with him for a few minutes to discuss these diseases. I always say that if you're presenting during the review course, that's when you know that you've made it. In this episode, we discuss thrombotic thrombocytopenic purpura, or TTP, hemolytic uremic syndrome, or HUS, and antiphospholipid syndrome. Dr. Ortel gives us his insights on diagnosing these disorders in people with rheumatic diseases, initiating early treatment, and looking ahead to novel therapies coming down the pipeline. Certainly, these are important diseases to recognize, as they can have devastating consequences for patients if not identified early. Dr. Thomas Ortel is Professor of Medicine and Pathology at Duke University Medical Center, Chief of the Division of Hematology, and Medical Director of the Clinical Coagulation and the Platelet Antibody Laboratories at Duke. His primary clinical interests and research expertise are in hemostatic and thrombotic disorders, with a focus on rare antibody-mediated thrombotic disorders, including antiphospholipid syndrome and heparin-induced thrombocytopenia, as well as the development and management of novel antithrombotic therapies. Enjoy. Tom, welcome to the show.
Thank you, John. It's good to be here.
So, thrombotic microangiopathies, or TMAs, why do rheumatologists need to care about these disorders?
So, thrombotic microangiopathies are disorders characterized by damage to the endothelium, the cells lining the blood vessels, and lead to vascular occlusions. They can occur very rapidly. They can have very bad outcomes, including renal failure and also mortality. And they can be associated with certain rheumatologic conditions. So, patients with antiphospholipid syndrome, patients with lupus, patients with scleroderma can develop these thrombotic microangiopathies that have to be treated specifically as soon as they are recognized to try to prevent these bad complications from developing.
Yeah, so what are those TMAs that are associated with these syndromes?
So TMAs include the classic defined thrombotic thrombocytopenic purpura and also hemolytic uremic syndrome. Those are the two that have been best described that are out there and that we have treatments for. But thrombotic microangiopathies can also occur with malignancies, with infections, with a variety of autoimmune disorders, severe hypertension, organ transplant, drugs, etc. So there's a lot of things that can lead to this kind of common shared phenotype, which includes the presence of fragmented red blood cells on a blood film, includes low platelet count, includes elevated LDH, and a decreased haptoglobin, all of which are markers of hemolysis, which fits with the microangiopathic hemolytic anemia piece of this.
Got it. So it sounds like often these TMAs are sort of similar pathways get activated, maybe by a variety of different stimuli, whether it's autoimmune, whether it's drugs. Some of these may be hereditary, and they all lead to sort of a similar presentation in that, low platelets, hemolytic anemia, and is that right?
Hmm. Right. There can be a couple different mechanisms that get you there, but there
Hmm.
are some shared themes, if you will, across different disorders.
Got it. So let's start talking about TTP in a little bit more specific. So, in terms of our rheumatic diseases, which are the ones that are most closely associated with TTP?
So TTP, or thrombotic thrombocytopenic purpura, is a disorder that's specifically characterized by a very low level of a specific enzyme. And I'm not going to give the whole name of it. I'm just going to call it ADAMTS13 or ADAMTS TS13. And when that level gets extremely low, all of a sudden you have the potential for von Willebrand factor to cause these activation of platelets, to cause a variety of things to happen in the plasma that leads to endothelial activation, leads to vascular occlusion, and things like this. So TTP can occur as a freestanding entity in a patient who doesn't have any other condition. They have an autoimmune process that leads to a low ADAMTS13 and the development of the syndrome. TTP can also develop in patients with lupus. And so TTP is one of the mechanisms for a patient with lupus to develop a thrombotic microangiopathy. They can also have other mechanisms that lead to the development of a thrombotic microangiopathy. But the key is you want to check an ADAMTS13 level in these patients quickly, because the treatment for TTP is very different than the treatment for many of these others. And you want to make sure that you're treating it correctly. So
Got
the
it.
having that low threshold of suspicion that it could be TTP developing in your patient, and sending off the ADAMTS13 level and then initiating therapy is critical.
Got it. And the mechanism by which patients with lupus might develop TTP, is it autoantibodies against ADAMTS13 that reduces its function?
For those patients with lupus who develop TTP, they will have antibodies against the ADAMTS13 that decreases the level of that protein.
Got it. And what's the you're sort of highlighting that it's very important to send an Adam TS13 in these patients because certainly, we need to initiate treatment quickly. What are the sorts of patients or what are the clinical manifestations that might make you concerned about TTP in a patient with lupus?
So, what would make me more concerned about TTP versus hemolytic uremic syndrome or complement mediated hemolysis would be the patient has new onset or exacerbation of thrombocytopenia, new onset of schistocytes on the blood film, which are these fragmented or torn red blood cells, um, a haptoglobin that goes very low because the haptoglobin binds the heme as it's released from the red blood cells when they're damaged, and high LDH. So those kind of laboratory
Hmm.
manifestations. So exacerbation of anemia. So the patient might have very general symptoms, might have just fatigue, but can also have neurologic symptoms, etc. If the patient presents, however, with more renal or kidney related symptoms, then it might not be TTP causing the TMA. It might be one of these complement mediated processes that can also cause a thrombotic microangiopathy in a patient with lupus.
Got it. Tell me about some of those, sort of the kidney presentations of TMAs.
So the classic disorder is TTP is one side, hemolytic uremic syndrome is the other side of this, and that's patients who also have those same findings, the fragmented red cells, the decreased platelets, etc. But more characteristically, they also will often have acute kidney injury, often leading to the need for dialysis. In contrast to patients with TTP who usually don't have that.
Hmm.
So, patients who develop problems such as lupus related complications with kidney insufficiency or acute kidney injury, you have to look for the presence of this hemolytic uremic syndrome variant or complement mediated hemolysis, because there you're going to treat it differently. Now, the problem with it is that right now it's a diagnosis of exclusion, as opposed to us having a nice laboratory test that you can use and turn around quickly and say,
Hmm.
this is a patient who has a complement mediated HUS. In contrast to TTP, where you have the ADAM TS13 level that very quickly tells you if you have the TTP piece, we don't have that for the
Hmm.
complement mediated disorders. The big distinction is the treatments for the two are different.
Of course. Okay. Got it. All right. Getting back to the TTP. Um, so, in addition to the lab abnormalities, you were mentioning sort of symptoms that patients may present with anemia. What are some other, I mean, symptoms like fatigue? What are some other common presentations? What do patients feel like when they have TTP? Any neurologic manifestations or other things that often go along with this?
So it's it's a variety of things that are very non-specific. Let's put it that way. Patients with TTP can present with fevers, they can present with fatigue, they can present with a variety of neurologic manifestations. And that's part of the overall syndrome. And it can be everything from presenting with the phenotype or the symptoms of like an acute delirium. It could
Mm,
also be an acute stroke
mm.
presentation. It could be a variety of manifestations like that. Again, none of which are specific for TMA or for TTP, but should make you suspect that something could be going on. So if you have any of those kinds of manifestations, you have to be aware of that.
Got it. And then for the hemolytic uremic syndrome, do those patients often have also more systemic symptoms, or are their symptoms more limited?
Well, their symptoms can be related to symptoms associated with renal
With
failure,
Yep,
so fluid overload, things like this. They can also develop problems with high blood pressure.
got it.
Hypertension could either be contributing to it or be a symptom of it. So if the blood pressure's up, if there's other symptoms, shortness of breath, etc., that might be related to fluid overload, you could think of renal insufficiency. But in general, the neurologic manifestations are not as prominent in the HUS as opposed to TTP.
Got it. And for management of for diagnosis of HUS, you mentioned that it's sort of a diagnosis of exclusion, but would you biopsy those patients to try to make sure, is this glomerulonephritis or TMA or something else?
Well, definitely in a patient with lupus who develops renal insufficiency or develops AKI, if at all possible, biopsy is critical because it may not be HUS. There are other causes of renal failure, as you know, and all the listeners will know. There are plenty of causes of renal failure in patients with lupus, so the biopsy is critical there, and it will show if thrombotic microangiopathy is present. You'll see the small capillaries occluded, so vascular occlusions will be present. So it does fit with part of the
Got it.
diagnostic workup, but it's really more just looking at renal insufficiency in a patient with lupus, wanting to know what's causing it.
Got it. Okay. And one of the things you mentioned earlier on was the importance of sending the Adam TS13, and that's a functional assay.
It is there are functional assays for it, but you can also get an antibody titer.
Okay.
If the level is low, you can detect if there's an inhibitory antibody present in that patient sample. So it is a laboratory based assay. It's a send out for most places. It's going to take anywhere from a couple days to maybe 3, 4, 5 days to come back
Wow. Yeah.
for
And
most
and
places.
I guess you were hinting at that it's important to consider this diagnosis because initiating treatment is very important. I understand that, in general, patients with TTP that don't get treatment often die. And therefore early recognition is important, and it's starting treatment often even before you have those results of the ADAM TS13 back.
So I did mention this thing called the plasmic score, and the plasmic score does give you some idea about the likelihood that a patient might have TTP. So you can use that as a tool to help you. And it,
Uh-huh.
it includes things like what's the kidney function like, whether or not there's a cancer present, whether or not there's a solid organ transplant present, etc.
Okay.
And you can kind of use that. And if you suspect TTP, generally you send off the ADAM TS13 and you start treatment for TTP, which will usually be plasma exchange as one of the first line pieces. There's new treatments coming along that are being studied as far as replacing potentially plasma exchange. But you start plasma exchange. And then by the time you get that result back, let's say day 3, day 4, if the result comes back and the ADAM TS13 level is above the cutoff, which is usually 10%, if it's above that, you can actually stop plasma
Hmm.
exchange because that isn't the best treatment. And then you need to be thinking about this other entity, the hemolytic uremic syndrome.
Huh. Okay. So do most patients with TTP present acutely, sort of in the emergency room inpatient setting, or are there patients walking around with TTP that may present in our clinics?
So you ask an interesting question from the perspective of there is a congenital form of
Mm.
TTP, Upshaw-Schulman syndrome, in which patients have mutations in ADAM TS13 and they have no ADAM TS13. And these patients actually can be fine until there are certain triggers
Hmm.
that may cause the disease to all of a sudden manifest itself. So a patient can have a very low ADAM TS13 level, be walking around and feel fine and actually be fine clinically, and then some trigger, which might be something like an infection, could trigger it. Could be a flare of an immune condition if they have that. Could be anything like that that might trigger it in those folks. Also, a lot of those folks, what will trigger it is pregnancy.
Uh-huh.
So, um, what's happened now is an evolution in how we approach TTP. So, as this assay has become more available, the ADAM TS13, a lot of people will have patients with immune TTP that they've treated. They've treated them with plasma exchange and steroids, and they may have given them rituximab. Um, and then you can follow the ADAM TS13 level, and it may drop before the patient actually develops any other manifestations of the disease and lets you know that the antibody is coming back and that you might need to treat that patient again. So the ADAM TS13 is becoming a very useful marker in the ongoing management of
Got it.
patients with TTP.
Oh, that's fantastic. So, you get your patient. I guess you'd have to admit your patient for plasma exchange. If you suspect TTP, is there a role for steroids or additional treatment aside from the plasma exchange in the initial few days of a patient with suspected TTP?
Well, currently, there's also caplacizumab that's being
Hmm.
used, which is targeting VWF and uh, preventing it from binding onto platelets, which is what's mediating that drop in the platelet count, the activation, et cetera. So, caplacizumab is being studied as actually potentially even an alternative to plasma exchange.
Huh.
Now, both of these, if you have an antibody driving the low ADAM TS13 level, you probably have to treat them with some kind of immunomodulatory component in there. And that definitely can be steroids, that can be rituximab, is usually a first line treatment of choice for that situation. Because if you don't get rid of the antibody, obviously, as soon as you
Yes.
stop the caplacizumab or you stop the plasma exchange, the platelet count starts to go back down. So
Yep.
that's part of the overall treatment strategy.
Got it. So I guess you sort of shoot first and ask questions later. You have plasma, your patient with suspected TTP. With you get him started with plasma exchange. Then I guess you have a few days. You could wait until the results of the ADAM TS13 come back, and if it's positive, then thinking about long term, how am I going to eliminate that autoantibody in the future, and thinking about things like rituximab. Okay, that makes sense. Um, for a patient with HUS, you mentioned that the treatment was actually quite different. If you suspect that your patient has HUS as the cause of their, hemolytic anemia and thrombocytopenia, how would you approach the treatment in those patients?
So this is where it gets interesting because we don't have that upfront diagnostic test that you can get that tells you this person needs this. Instead, what happens is if you have a patient who looked like TTP and you were plasma exchanging them, and then the ADAM-TS13 level comes back above
Hmm.
10%, then you need to change your treatment strategy. In that setting is complement mediated disorders. And so, in that particular setting, stopping plasma exchange and initiating therapy with a complement inhibitor such as eculizumab would be the treatment of choice. There, you're blocking at the level of C5, and that is extremely valuable because it improves renal function in people with
Hmm.
HUS, it improves platelet counts quickly, et cetera. So, unless you know somebody the only way that you might suspect it is if you did a plasmic score and the patient completely fails the plasmic score, but they otherwise kind of look like TTP, which is a little odd. But
Uh,
if it did happen, you could go to eculizumab first. Now, eculizumab has been used as kind of a bailout therapy for patients with TTP that don't seem to be responding, and it should be used for people in whom you end up diagnosing them as having HUS.
Got it. And similar question to what we discussed in patients with TTP. In people with HUS that you diagnose with HUS and you treat with whatever means possible, whether it's complement inhibition, is there a need for long-term immunosuppression or something to prevent that from recurring? Or is that a less of a concern in HUS?
So, this is an interesting question because also in HUS, what's recommended, and you can check a variety of complement assays. You can check C3, C4, CH50, etc. Those are neither specific nor sensitive, but
Hmm.
they may give you an idea if something is going on. But one of the things that is recommended at some point is consider sending genetic testing
Hmm.
because a third to 40% of these folks may have mutations in complement regulatory proteins. And in that setting, long term immunosuppression may not help, but you may not need to continue eculizumab indefinitely. There's actually a number of people who are looking at this. How do you taper off? Who do you decide when to stop? What criteria do you use? People are looking at that in this syndrome to see if they can come up with strategies for when to turn things off because it doesn't have that. You don't use the Rituxan or other things like that in this setting.
In the Got it, in the HUS model. And I understand HUS can be sort of triggered by what did we learn in medical school? By certain infections, right? The classic, what is it, Shigella, that
Mm-hmm.
that often
Shiga
triggers
toxin.
Shiga toxin. That's right. Going back to
So now
medical.
that's the so this is where it also gets confusing because there's so many names and acronyms that are all floating around this entity of thrombotic microangiopathy. The Shiga toxin induced hemolytic uremic syndrome typically usually will present with diarrhea often and have renal insufficiency, etc. And it's a very different mechanism
Hmm.
than the complement mediated ones, which used to be called atypical HUS because they didn't have the Shiga toxin driving it.
Huh.
But at the end of the day, both of them have kind of this similar clinical manifestation of acute renal insufficiency, hypertension, etc., um, with MAHA, the microangiopathic hemolytic anemia present. So in that setting, the Shiga toxin one is a different kind of beast, if you
Hmm.
will. You treat it differently than the non Shiga toxin or complement mediated one. The Shiga toxin is also usually more frequently in pediatrics, but it occurs sometimes in adults. But it is a different mechanism. So it gets back to this concept that the thrombotic microangiopathy, you find that based on the laboratory findings, but then there might be half a dozen different mechanisms that you could get to there,
Mm.
and have that develop.
Got it. Are there other risk factors aside from the presence of autoimmune conditions like lupus that may predispose patients to, for instance, TTP or some of these other thrombotic microangiopathies that are not, aside from like genetic things?
Right. So thrombotic microangiopathies can occur with a variety of other conditions, and people have looked at this. You can get it with malignancy.
Mm,
You can get it with certain infections other than just Shiga toxin. You can also get it with certain E. coli
mm,
subspecies. You can get it with certain other kinds of infections. Um, you can get a thrombotic microangiopathic picture presenting from severe hypertension. So, if you remember, the hypertension crises can give you also a TMA like picture. Pregnancy can do it. And there's some confusion there around the setting of developing thrombocytopenia and the timing to when the woman delivers, et cetera. Is it really something called HELP, or is it something called TTP, depending on when it develops in relation to when the woman delivers? And there are an expanding number of medications that are associated with developing what looks like a thrombotic microangiopathy with schistocytes and low platelets, et cetera. So there's a number of different things that can do it, some of which would respond to complement inhibition, some of which won't, obviously, some of which respond to plasma exchange, and some of which don't. So,
interesting. Interesting. And in our lupus patients, we talked about TTP. But one of the other conditions that we often encounter and that we often struggle to treat is antiphospholipid syndrome. So, what are your thoughts? So, where does antiphospholipid syndrome fit in with the thrombotic microangiopathies that we just discussed?
so there's a lot of overlap, and there's a lot of difference, as you can guess. Patients with antiphospholipid syndrome, just in general, can have microvascular thrombosis, so they can have that. They can also have low platelet counts. They can also have renal insufficiency. They can have all these things. But where you really see the thrombotic microangiopathic piece, at least in my opinion, is in the patients, that subset of patients with antiphospholipid syndrome who developed a catastrophic variant. The
Uh-huh.
catastrophic APS very characteristically will often have microangiopathic hemolytic anemia, the thrombotic microangiopathy affecting the kidneys, the lungs, etc. So, in that setting, you really are getting over into a thrombotic microangiopathy, not usually TTP, but you could check an ADAM-TS13 level on them. But usually, if you know they have antiphospholipid syndrome up front, you're going to treat them as if they have catastrophic APS.
Got it. Okay. So getting back, sort of beginning to think about APS in patients with lupus, I guess, you can often have autoantibodies that don't seem to be causing the syndrome. And then you have patients who've had either obstetric complications or clots that have, the full antiphospholipid syndrome. I always struggle in patients with lupus who are, sort of presenting to clinic for the first time and who've never had a blood clot, whether or not to check antiphospholipids. Because, it's my understanding that, medications to prevent that first clot, it's not so effective. I don't know if you have thoughts about, I guess you as a hematologist, do you want to know that information up front in patients that don't have history of blood clots?
Well, I think it's useful in the lupus patient population because it is also part of the diagnostic criteria or
Sure.
the classification criteria for lupus. So it does get checked a lot there. And what you do see is not all patients with lupus who have antiphospholipid antibodies go on to develop a thrombotic complication or pregnancy, morbidity, etc. So sometimes they're there and they may be clinically irrelevant. Sometimes they are there and the patient really has antiphospholipid syndrome more so than lupus even.
Hmm.
Um, I think that for taking care of patients with lupus and knowing when to anticipate things, checking antiphospholipid antibodies does make sense in that patient population. I do agree with you. The role of primary thromboprophylaxis in that group is very sketchy. Most people would recommend, if I had lupus and I was tested and I had antiphospholipid antibodies, a lot of people would say that person needs to have aspirin. But the data for aspirin actually doing much is not great.
Hmm.
So if the patient can tolerate it and is not having any problems with bruising, etc., aspirin is not unreasonable. But there's nothing that recommends doing more than that.
Yep.
Now, there are some patients with lupus who also have antiphospholipid antibodies who probably develop a TMA that may be more directly related to their APS rather than TTP or
Hmm.
HUS, either one. So that's another mechanism that a patient with lupus could potentially develop a thrombotic microangiopathy.
Got it. And so those patients would present with similar microangiopathic hemolytic anemia and thrombocytopenia
Yep,
as driven by their antiphospholipid antibodies.
right.
Yeah, great. So in patients uh, with either lupus or not lupus, but who have the antiphospholipids and have histories of um, obstetric complications or thrombosis, why don't direct oral antagonists work? Or I think vitamin K antagonists are the recommended treatment for those patients who have the antiphospholipids and have already histories of blood clots. um, but why do you think these newer agents aren't as effective?
So it's an interesting question. The so the direct oral anticoagulants don't work for all conditions. For example, they aren't very good at preventing clots in people who have prosthetic heart valves.
Huh.
So warfarin is still the treatment of choice there. And they don't work, especially in patients with triple positive antiphospholipid syndrome, the people who have the lupus anticoagulant, anacardiolipin, and anti-beta 2 glycoprotein 1. So in those groups, you definitely want to use warfarin or a vitamin K antagonist. The interesting question is in a patient, for example, who, let's say they have a DVT and they only have an anacardiolipin antibody positive. It's not completely clear if the direct oral anticoagulant might not be effective in that subset of folks. So the
Hmm.
ones that only have one antibody positive, et cetera. Now, it's not just a matter of degree of severity of the thrombotic risk, et cetera. There's something else going on because, for example, the direct oral anticoagulants do work very effectively in patients with cancer and thrombosis, which is another high risk thrombotic complication. So at this point in time, we don't know why specifically the DOACs don't work, but the suspicion is that it's related to just the antibodies and the mechanism of thrombosis in that cohort.
Got it. And yeah, I always wonder about the role of other medications. So let's say you do have your patient on warfarin. Is there any evidence that other medications, such as like hydroxychloroquine, do they also help prevent other, additional thromboses? Or how would you think about patients who are on warfarin and continue to have clots despite the use of, appropriate levels of warfarin?
So now you're getting at both extremes. Um, the um, hydroxychloroquine story, some people do use hydroxy, or there is some evidence that would suggest that hydroxychloroquine may help prevent a first thrombosis in in a patient with, let's say, lupus who has antiphospholipid antibodies, et cetera. So it has been used that way. And you could use it. The data are less in patients with primary antiphospholipid antibodies, let's say.
Okay.
Um, but the the additive effect of hydroxychloroquine on top of anticoagulant therapy hasn't been shown, hasn't been
Hmm.
documented. Now, when you get to the next extreme, you get to, okay, the person who's now had thrombotic events and they've had recurrent thrombotic events on therapeutic anticoagulation, clearly documented. You can go to additional strategies such as adding an antiplatelet agent to the anticoagulant to try to increase the antithrombotic efficacy. But there's also, at some point in time, you're going to want to reach for, maybe I need to do something to try to treat the antibody, to
Mm.
try to get rid of the antibody, and maybe that will improve outcomes. These are anecdotal reports, but people have used rituximab in these folks. People have used eculizumab in refractory antiphospholipid syndrome. Um, People have done bone marrow transplants in these folks. So all sorts of things have been tried, but there's nothing that's been proven. Now, the Immune Tolerance Network is just starting a clinical trial that's being run by Doric Erkin and Jason
Mm.
Knight, looking at daratumumab, a safety study in patients with antiphospholipid syndrome, triple positive antiphospholipid syndrome. And daratumumab is an antibody that's used right now mainly in multiple myeloma because it targets the B cells.
Mm.
But it's looking at a new mechanism to potentially lower antibody levels and then see if that has an impact on thrombotic risk in those folks long term. But the trial that's out there right now is just making sure that we're not running into dose limiting toxicities with daratumumab in a patient population that's got triple positive antiphospholipid syndrome.
Got it. And in people with APS, we often, there's the like non-criteria manifestations that we sometimes don't think about as often. From a patient's perspective, patients that have APS, what other symptoms do they feel that may be related to APS that sometimes we sort of ignore or overlook?
So I think it's very important not to overlook them, and not to miss them when the patient complains about them. Um, Unfortunately, we don't have good treatments for these things, is part of the problem. Um, but commonly, patients with antiphospholipid syndrome may have mild thrombocytopenia. They may have livedo racemosa, rash, uh, uh, reflecting microthrombosis. Uh, they can have renal insufficiency. They can have cardiac valve disease that gets to the point where they need a heart valve replaced. They So there's a variety of other manifestations that aren't considered part of the classical classification criteria for APS. But I would say that the new classification criteria that were sponsored by the American College of Rheumatology and EULAR just came out. And one of the issues that was recognized was that we needed to give more weight to some of these non criteria symptoms, recognizing that patients do get them. But this includes all sorts of things. There's a whole variety of non thromboembolic neurologic manifestations that these patients get. I would say that most of my patients do complain about having brain fog,
Hmm.
is a common complaint. Fatigue is very common. So a lot of that. And some of that may be helped by things like hydroxychloroquine
Hmm.
or may be helped by other interventions. But usually the anticoagulant alone isn't going to help those.
Okay. And trying to tie back a little bit of the APS story with with the TMAs. You mentioned briefly about CAPS, or catastrophic antiphospholipid syndrome. Can you tell a little bit about how do those patients typically present in the hospital? Like what are common presentations, and then what should we do about them?
The key there is recognizing that that patient has got a catastrophic manifestation, because you need to rapidly introduce treatment. Similarly to what you had mentioned at the beginning of our discussion about this idea that TTP used to be almost uniformly fatal until the 1980s or so, when people recognized that if you did plasma exchange, you could almost make it uniformly survivable.
Hmm.
So you could really change the impact. Same with catastrophic APS. If it's not recognized as what's going on, that patient has a very high mortality rate. So usually, where I get suspicious or where I want to make sure I know that there isn't something going on that's getting worse is if the patient's having new thrombotic events, if they're clotting through something, or if I'm worried that they're clotting through something, um, if their cytopenias are getting worse, if something else is changing in them that makes me think maybe there's something evolving or something going on there. But by definition, for catastrophic APS, you're looking for the occurrence of three or more organs or systems being involved by some thrombotic complication, which frequently includes microvascular or thrombotic microangiopathies as part of this in the kidney or in the lungs, etc., or in the adrenal glands, and may look more like a bleeding event rather than a clotting event, but it's related to the small vessels clogging off, and then
Hmm.
the patient bleeds around that. And
Hmm.
so you get bleeding manifestations. So I get more concerned about people whenever I see thrombotic microangiopathic manifestations, whether it be dermatologic, renal, etc. I get more concerned that that person might be at a higher risk to have something going on.
Got it. I think, the challenge often is certainly if a patient is known to have N-phospholipids and they seem to have some of these things, it's easier to make the diagnosis. We've had patients present to the hospital that don't have any history of autoimmunity. And certainly, even just thinking about sending the N-phospholipid antibodies is tough in some of those patients that have uh, thrombotic manifestations, as you mentioned.
Right. It's estimated that I want to say something like a third to 40% of people who ultimately get diagnosed with catastrophic APS did not have a pre existing diagnosis of APS before they presented.
Hmm.
So, somebody coming in with one of these rapidly progressive thrombotic phenotypes, multiple places with clots, arterial side, venous side, microvascular stuff, that's when you have to have that quick suspicion. And as with so many things, if you're going to start plasma exchange because you're not sure if it's TTP or CAPS or whatever, draw the test and send the test off and go ahead and start treatment right then, because you'd rather not start the treatment and then think about it and try to get the tests after you've been exchanging somebody's plasma. So a lot of the IgG in there is
Ah,
not theirs anymore.
it's a
Uh,
good point. Yeah, so send the, if you're worried about TTP, the ADAM-TS13, and if you're worried about CAPS, the antiphospholipid antibodies. Do you find that you often send both? Like, are you is there enough overlapping manifestations that you often are sending both when you're dealing with these very sick patients?
it's not unreasonable to do that because it's going to have a big impact in what you might decide to do 3, 4, 5 days later. Um, but clearly, if somebody comes in and they have any of these non-thrombotic manifestations suggestive of APS, like if they
Mm,
have livido all over their torso or whatever, if they have something that makes me think more, this looks a little more like CAPS. I don't necessarily need the Adam TS13, but if I've got the needle in their arm, I'll usually send both.
got it. Okay. And tell me a little bit about CAPS management. I think for a long time, uh, we used sort of triple therapy um, as the management of CAPS, and now there may be some other stuff. So, triple therapy is anticoagulation, plasmapheresis, or via IVIG and glucocorticoids. Is that right?
That's right.
And should most patients, that you suspect they have CAPS, just start that from day one?
I would recommend starting that from day one. If you think it's CAPS, I would treat it that way. And again, I think as we've mentioned with a couple of scenarios, you may have a patient who seems to be refractory to that, and you may reach for eculizumab
Uh-huh.
at some point down the line, but the standard of care first line treatment would still be, as you mentioned, classic triple therapy with anticoagulation, steroids, and plasma exchange or IVIG.
Got it. IVIG versus plasma exchange. Is there?
I personally use plasma exchange first. Now, if you had somebody who may have some reason that you can't plasma exchange them right away, IVIG is a reasonable first line alternative to plasma exchange. Don't give them IVIG though, and then plasma exchange them right afterwards because that doesn't help much.
Yes, yeah, you're just taking out all the stuff that you put in. Very good. And then I guess in those patients, if they have CAPS, again, thinking about removing the autoantibody with things like rituximab so that this thing doesn't happen again. What are common triggers? Like I always, patients that have antiphospholipid syndrome or that have they have the antibodies all the time and they don't present with CAPS most of the time. So, what is it that triggers them to develop this like horrible syndrome that for which they need hospitalization and a whole bunch of treatment? What tips them over the edge?
So there's probably a couple of things involved. One thing that's involved is that there has been a study that showed that patients with catastrophic APS are more likely to have mutations in these complement regulatory proteins than patients who don't develop catastrophic APS. In fact, the frequency of these mutations is comparable to the frequency of the mutations in patients with hemolytic uremic syndrome. So I think it's
Hmm.
worthwhile, if you have somebody that you diagnose with CAPS, to test them for those complement mutations, because that might identify a person who can develop it again in the future. At the same time, there are clearly triggers that can push people into developing CAPS. And those triggers include a variety of things that are very almost everyday-ish in some ways. Infections can trigger it. Being subtherapeutic with your warfarin can
Mm.
trigger it, or withholding the anticoagulant for a period of time. Pregnancy obviously can trigger it. So you do have these triggers that maybe set it off. So it may be a patient who has antiphospholipid syndrome who also has some mutations that compromises their ability to control complement, and then you give them an infection on top of that, and it's
Got it.
it's that perfect storm of presenting symptoms that are presenting findings that just lead to the syndrome. That being said, in patients with CAPS, you don't always find that there was a precipitating event either. So it usually happens, but it's not always there.
Hmm.
This is
Great.
also one of the things that led to a lot of concerns, for example, in patients with APS and getting
Hmm.
vaccinated with COVID, et cetera. Will that trigger some thrombotic event or CAPS and stuff like that? We have no data for that, although it would seem that that is a potential, but we haven't had that happen.
Fascinating. So we've spoken a lot. I think you've certainly uh, explained very, very well about sort of the thrombotic microangiopathies. We talked a little bit about TTP, HUS, and most recently, antiphospholipid syndrome and how those may be more common in patients with autoimmune conditions like lupus. Looking forward, what are some of the questions that still need to be answered, or what are the things that excite you most about sort of the future of TMAs and either how we diagnose them or how we treat them?
So one of the things that there's a lot of interest in, and we don't have yet, uh, is the diagnostic test for HUS.
Mhm.
Something that you can order and get it turned around quickly, and then start somebody on eculizumab, which is not an inexpensive treatment. So I think one of the things that's going to be very exciting to see develop is how or when we will identify a test that we can implement that will help us in the management of these patients, and especially the diagnosis, accurate diagnosis of what's causing their TMA. And then I think, as we've learned that by inhibiting complement, you can really improve outcomes in patients with HUS. Not all patients respond to that. So
Hmm.
we do need additional treatments or alternative treatments. And it may be that C5 isn't the right one to be targeting. Maybe there's another one that needs to be targeted. And people are looking at inhibition at C3 or C1 and et cetera, trying to find other mechanisms to control the complement response. So for me, I think what's going to be neat, and what we've seen with TTP, for example, is better diagnostic tools and new therapies that we can intervene with that are more targeted towards the mechanism and not just trying to treat the manifestations.
I love it. Tom, this has been a very enlightening discussion. I really appreciate your help in trying to, you know, sort of make sense of all of these acronyms that we often have, and how we as rheumatologists certainly need to understand them, to be able to diagnose them, and to help, I guess, often with our hematology colleagues, you know, in implement some of the treatments. Um, Thank you so much for your time.
Thank you very much for asking me to call.
Well, there you have it. Everything you ever wanted to know about the thrombotic microangiopathies as they present in people with rheumatic diseases. Remember to tune in each day this week for new episodes during our special coverage of ACR Convergence on Air 2023. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep a close eye on your patients' CBCs. And of course, stay healthy.